and we create AI solutions for the societal problems. And not only we create it, the charter of the lab is that we should be able to scale it up and make it population scale and roll it out as digital public good. That's the goal that we have. And without any further ado, let me just set the context. A few years back, I was actually busy in creating a very population scale program for government of Karnataka for the frontline workers called Anganwadi workers who take care of children, their nutrition, etc. And it cut across 3 ministries. We trained about 65,000. We integrated the data and the processes which were all over the place. But at the end of it, no, there was one big learning that I had. And that has been, and it was quite a few years back when these were not even buzzwords. That was training 70,000 officials and frontline workers, was that the success? Was integrating processes the success? Was cutting across the ministries and making everything work? No, adoption does not happen because of these reasons. They are all important for the solution. Adoption happens when you are able to get, I know the previous session must have talked about it, when you can talk about the trust, when you can talk about the empowerment, when you talk about the enablement of the last mile worker who is going to be the end user. And morning I was privileged to be part of another session where I was able to speak briefly. It was a compendium launch of AI in various things. And there was a speaker from UN Women who made a very poignant point in the morning that when you are making AI, and she was talking about the gender divide, which is very much relevant to our topic. She said that if you are creating an AI solution which is focused on bridging the gender divide, then two things are important. One is that AI should be intentional. It should not be just that because there is a technology you are dropping it there. And you don't create AI solutions for the people. You build them with them. And I think that was a very poignant, because not in so many words, but this is for something that I had learned in my past. And I think it made all the more sense, that we should dictate. And that is the lens. You talk about skilling, people think about training. Skilling is not training. It goes for the whole, it's a continuum from the trust, the solution design, right up to when you give some solution into their hand for their daily use. And it is that lens which we will use for our discussions today. We have got a very rich panel here. And the point of this panel is that each one of us, including myself, are practitioners. We are not solution creators in the lab. We are not, what we do goes out into the field. So I'll quickly introduce my panel. And it is a very good mix of people who actually create solutions, who are managing the field deployments right up to the last mile. We have people like that, and we have somebody who is policy maker and who looks at the larger administration part of it. And that's what we will do today. We will keep it very high energy discussion. But first I will want to set the stage by inviting Ms. Tanushri Dev Burma. She is the head of the Tech Center for Aadhaar at UIDAI. So she heads the technology division, and she has done many roles. I will give a brief introduction to her. I want her to ground the discussion with some of her perspective, because she has played various roles in various departments, including women and child and other things. She right now serves as a Deputy Director General at UIDI and is the Head of Technology Center and Data Center for Aadhaar in Bengaluru. She works at the intersection of national scale digital identity infrastructure and applied technology delivery. Her work focuses on strengthening the robustness, security, and reliability of Aadhaar systems and services. She has done on various technology solutions related to Aadhaar. I will not go through that. But she has also served in various capacities in the state government of Tripura and Karnataka, notably in the departments like information technology, finance, revenue, and tribal welfare departments. So before I go ahead and introduce the other panel members, I would like you, Tanushri, if you can come to the podium and set the ground and give a contextual setting, and then we'll take it forward from there. Welcome.
Thanks, Ashish. So it's a privilege to be here. So I think Ashish missed mentioning that I was also Director Child Protection in Karnataka and Director Basic Education, Primary Education in Tripura. These were my earlier, younger days, and much more energy and aspirational thoughts that you can change a lot of things. Uh, what has changed from then and now, and there is a story about as officers become older, they become more cynical. And you get beaten down by politician नहीं सुन रहा है, पैसे नहीं मिल रहे हैं, finance नहीं देता है, government of India नहीं देता है, and all those things come together and sort of bog you down from the initial enthusiasm with which you start. But the fun part is that coming from a technology background, you always knew that no matter how many externalities can bog you down, you can come out of it with the use of technology. And that's the hope with which I have always worked. And I would like to take you back, and some of you can Google it, that there is a district called Khowai in Tripura, which was in 2013 or 11, the worst in terms of immunization, right? Why does that happen? Because the population is too spread. The health worker cannot cover as much population. It's tribal area, so there is resistance to medical care, not the same way as a Delhiite would accept it. So urban rural divide, on top of it religious and different ethics, and which prevent the acceptance of immunization per se. From there, within a year, we took an initiative which was called Mission 100, where we wanted to cover the entire population of under 1 year age of children under the 6 doses of immunization, right? And how does that happen over 1 year? Because there is a engineer sitting behind and can explain to the doctors that these are the numbers you have to chase, right? And that was my first learning experience on how numbers can create a pull. At the same time, it has to be converged with training, enablement, and understanding of the overall goal. So, of course, like Ashish mentioned, we did lot of training, lot of ground level understanding, lot of DM inspections, going to remote areas and trying to open all the registers that they had to maintain. And at the bottom of my heart, I felt so bad that 6 register maintain karne padte hain. And all of it, I mean, even for me, after so many years of education, and it was difficult to understand, let alone the Anganwadi worker and the Asha worker, right? And they have different registers to be maintained, which they have to match and then collate and make sure that the records are right. So with that kind of a challenge, we worked, and Excel sheet after Excel sheets being explained at each level, right down to the Anganwadi worker के आप यहाँ पे हो, आपको यहाँ पे आना है, इसके लिए आपको ये करना है, आपको जाना है, उसको ये समझाना है, उसको ये immunization 6 dose है, 4 dose है, booster देना है. Everything we had to do, and within a year we reached like from 60 something percent to 90 something percent, and 2 years we reached 100%. And after I left also, almost after 7 or 8 years, it still maintained as the highest immunized district in all of Tripura, right? So why and how these happen is because you set systems. You have those MCTS, us time hota tha. So we explained, we were the first district to adopt MCTS. But coming from that experience today, when I'm in UIDAI, the same things come across, right? We have 140 CR people with Aadhars. They are using their biometrics 8 crores times a day, right? We do 8 crore authentications per day. We have to ensure that even the remotest area, if they want to use their Aadhaar, they can do it with as much simplicity as possible. And for that, we adopt AI and technology within UIDAI, ensuring that the match rate of your finger when you present it on a biometric device is higher each day. We keep making our models better. The deduplication rate at which you trying to get your second Aadhaar is better every day. False positives do not come. I can uniquely identify you. And if somebody is trying to break the system, we can, through fraud analytics, understand it. So these two things converge, and what I wanted to get to was that it's very critical that you enable technology not for the sake of technology, but to enable the people and give the benefit to the people, and that is the theme of today's summit also. It is an inclusive approach. It has to ensure that the intent of technology is met, and for that, if you have to do ways and means around it to ensure that the technology reaches people, we have to figure that out, and that is where humans come in. The human intelligence, empathy, understanding will come in. And I got to speak to Khushi Baby as well as Arman's work that is being done, and they'll speak more about it. But I think today's people, today's administrators, their job is so much simpler because of technology being there, and we have to make sure as responsible government officials and civic society officials, we have to take that technology to the people and make sure that the benefits are reaped by the very last mile beneficiary. Thank you.
Thank you, Tanushri. Let me right away, without wasting time, invite and introduce the other two panelists. On my right side, Amrita Mahale, Director of Product and Innovation at Arman. And on my left is Hamid Abdullah, Implementation Lead at Khushi Baby. Okay, and both of them have been deeply involved in the topic that we are going to discuss today. So why don't I start with Amrita and then with Hamid. First, introduce yourself and your organization. Your solution, we'll talk enough about it later. So, but if you can set the context, it will be great.
Yeah, my name is Amrita Mahale. I lead product and innovation at Arman. Arman is a non-profit focused on maternal and child health with an emphasis on preventive care. And we run two kinds of programs. We run large-scale tech plus touch programs. One category of programs is focused on empowering pregnant women and mothers of infants with critical preventive care information to improve health-seeking behavior. And the second category of programs is focused on health workers and health systems, where we train and support health workers to provide better quality of care with the overall objective of reducing maternal and child mortality and morbidity. And the product team at Arman follows a human-centered, data-driven, evidence-based approach to innovation, and I look forward to talking more about some of our AI work today.
Hi everyone. My name is Hamid and I am from Khushi Baby. I'm working as an implementation lead, and Khushi Baby is also a non-profit organization, and the work Khushi Baby is doing is that we create solution for the community health worker and also for the health officials. So we have created a platform that we called it Community Health Integrated Platform. It is an integrated platform which ASHA, A&M or other community health worker can use, and it is integrated with the dashboard, so the health official can also see the activities which is happening on the last mile by the community health worker, and they can also take action on these activities whatever community health worker is doing. And we have also created solution like we have created Samvadini. Samvadini is a LLM model which is on the dashboard, and if any health official want to use, they can just put normal queries on the dashboard and get the insight of the data. So yeah, we have created these type of dashboard.
Yeah, thanks Amrita, thanks Hamid. I think now let's deep dive a little bit more into the question and start at the first point. I want to align with the topic that we have. We are talking about AI here. So let us first explore, like, where does even AI show up at the front line? Okay, so I think I will start with maybe you, Amrita. And how are your solutions using AI today in the front line, in the citizen-facing journey? You touched upon a very interesting concept called tech plus touch, how that actually blends into with your solution. Can you just explain that?
I'll talk about one of our AI solutions, the one that's in some ways the most mature. But first, let me set some context about why we picked this particular solution to work on. A woman dies in childbirth every 20 minutes in India, and for every woman who dies, 20 more suffer lifelong complications. And only 20 to 30% of pregnancies fall into what could be considered the high risk category, but they account for 70 to 80% of deaths. There are many reasons why these deaths happen, even though they are preventable. Many of them are preventable. But a key factor is that India's frontline health workers, who are the first point of care for pregnant women, India's community health workers are overworked, they are undertrained, and they lack access to support at the point of care. One of our larger programs called IHRPTM is focused on training health workers to manage high-risk pregnancy better. We've developed detailed protocols for what needs to be done at every level of the health system: community, primary, secondary, tertiary. And these protocols are first imparted through classroom training. But what we quickly learned is that classroom training has limitations. It's infrequent, it's one size fits all, and whatever health workers learn, that knowledge degrades over time, which is why we decided to invest in digital learning and support. And the solution I want to focus on in today's conversation is a knowledge assistant, an LLM-powered knowledge assistant for health workers, for ANMs in particular, where they can use a WhatsApp-based helpline to ask any questions about high-risk pregnancy or antenatal care in their own language, either as a voice note or as text, and they get instant, protocol-aligned answers in a format that's user-friendly and easily digestible. So it's multilingual, multimodal. It's currently deployed in 3 states, and it's being used by about 6,000 ANMs. So that's close to, I think, 700, 800,000 pregnant women. And there is a human in the loop for safety. So the AI doesn't work alone. There is a human in the loop. So for complex queries that the chatbot does not understand, or where the ANM is not satisfied with the response she's getting, there's a medical trainer who steps in. So yeah, it's a multilingual, multimodal chatbot with a human in the loop that we've developed over the last 2 years. We did extensive user research. We did multiple rounds of expert evaluation before we deployed the solution. Even when we deployed it, we first started with a small cohort of 20 users, which went to 50, then 100, then 700. And the solution is live in 5 districts in UP. That's about 2,000 ANMs. And we've expanded to about 4,000 ANMs in Telangana, but the statewide scale-up is ongoing. So by the end of March, I think we would cover almost 12,000 ANMs. And it's live in Maharashtra as well. That's the 3rd state in a pilot setting.
Hamid, moving over to you. The AI, you also work on the LLM-based chatbots.
Yeah.
But how is it different from, say, what Arman is doing?
Before coming to this LLM chatbot, I just want to start from the ground reality. So if you see where Asha worker is standing today, with the community, in the village, with the high-risk pregnant men, with a newborn child, with the same children, and they have to do almost 54 type of activities. As Tanushri ma'am mentioned, that they have to maintain almost more than 10 register. Now, in the current situation, more than 5 application, and they have to maintain almost more than 20 programs. And it is very hard to remember all the guidelines, all the rules and logic for every program. So the idea to creating that chatbot for the community health worker, or specifically for the accredited social health activist, came up that it is very hard for a normal person to remember all these things. What we can do for the ASHA worker so that they can have the access of all these guidelines easily. So we created this LLM-powered AI chatbot that works on WhatsApp, because they are currently using lots of application, and it is very hard to ask them to use another application. So first thing we did, that we created this on WhatsApp. And the another thing is that we created the knowledge base of that chatbot on the basis of all the guidelines which they already aware and they already use under all these programs. And yeah, it's also work in both the local language. They can have the access whenever they want to use it. And currently we have deployed it in 5 districts of Rajasthan and 2 districts of Maharashtra. And yeah, I will talk more about how we have designed these chatbot for the community health worker.
Hamid, I'll just take up on your thing you were quoting and with your own experience that they have to maintain so many registers. One of the basic design principles which I can also tell with my experience is that how to roll out a solution that brings inclusion without increasing the burden, because that is the killer. If you, no matter how good and fancy your solution is, if it increases the burden of last mile worker, he or she is not going to accept it. So how did you actually work around it? I was not very clear, while I do understand that does your LLM chatbot, still they have to fill the registers, right? How do you actually facilitate that?
So yeah, if we see ASHA workers, so as I mentioned that currently they are using some register, and at the same time they are also filling same information in the application. And if you see, ASHA worker is more actively using WhatsApp for their official work also, and also for their some personal work. So what we did while creating this bot for the ASHA worker, the first thing is that it will be in their local language. So if ASHA from Rajasthan want to interact with the chatbot, they can use it in Hindi. And also if Maharashtra, they can use it Marathi. And another thing, while we were designing it, that because it is very hard for some of the ASHA to write their queries and to ask the question. So instead of, if they find it difficult to write the queries, they can just ask their question in voice message. And if it is hard for ASHA worker to read the answer, then they can also listen to it. So these are the things which was in our mind when we were creating this bot.
Okay, thanks. Tanushree, I will just jump to you, extending the same thing, because now you have to put your Aadhaar hat on. That when Aadhaar came, then there was a big risk that it might become the gatekeeper for the last mile, because for everything that is a KYC. How do you see Aadhaar playing a role at the last mile? And how do you take into your design considerations that it should not become an excessive burden or extra process rather than facilitation? How?
I think more than technology, though technology also plays a very important role, the ecosystem play that was brought in, right, that was very critical. So if we wanted to become the authenticator for every scheme, Aadhaar would have never taken off. It was designed so that we become the repository of your identity details, and it is you who will go to the person who wants to verify you and be able to verify seamlessly. And for that entire technology play, making sure that the AUA, the authentication agency, gets registered with us. It is a minimal API exchange between them and us, highly secure, making sure that the lines that carry your biometrics are secured, and the cryptography which makes sure that it is securely getting transferred, and made sure not just data at rest but data in motion is being met. So the technology, though very complicated, even talking about 10 years, 15 years back when it was envisaged, the principles were very basic to make sure that it is simple. You just have to put your Aadhaar number and put your thumb impression. You just have to put your Aadhaar number or show your iris, right? And that was it. Rest of it, technology was taking care of it. It was not made complicated on purpose. Otherwise, scaling would never be possible. Today, we have 300 plus entities who are our registered AUAs. And in addition, what we have recently implemented is that even if you are not a registered AUA, through verifiable credentials, the digital signature making of the credential, you will be able to offline authenticate yourself with any entity which is not an agency with us as well. So democratizing the way Aadhaar is getting exchanged, verified, was very critical. So earlier we did it through these means, and now because technology enables it, we are going to scale even more. So what I would like to say is that make it simple, understand what and how it will be used, minimize data requirement, minimize, and the design should be so simple that even the first time user gets it as easily as possible. So these design principles go a long way.
Thanks, makes sense. And what about you, Amrita? You talked about ANMs, your solution is, and in a high risk pregnancy case, how, and their ANMs are already loaded, last mile, people. What did you factor in your design? And we are talking in the context of AI and the last mile women empowerment. What was that you factored in your mindset that the burden does not come to them?
Yeah, that's a very good question. As I mentioned, that our overall approach to innovation and product design is human-centered. So before we'd written a single line of code, we spent time with ANMs on the ground in Telangana and UP to understand how they currently access information. What are the sources of information they turn to when they have a question at the point of care? We also learned, again, I mean, of course, this is something everybody is aware of the extent of digital fatigue among ANMs. And ANMs in both states that we did our user research in use between 6 and 13 different apps, portals, etc. Right? Some of it is seasonal. So we were very clear, as Hamid also pointed out, we did not want to add the burden of one more app. Right? Another learning that we got very quickly was that a lot of ANMs, especially older ANMs, are not comfortable typing long messages. So like I said, before we wrote a single line of code, we conducted Wizard of Oz experiments where we simulated a chatbot. There was actually a human at the other end who was responding using a script, but the ANMs thought they were interacting with a automated system. And they would break up the message into multiple messages, or they would not add enough detail. But as soon as we told them that they could use voice notes, the questions automatically became richer. There was more context. So it was easier to provide a useful answer when the question itself was more meaningful, was more detailed. Another thing we learned, and this was very interesting, was around the tonality of the answers. It's very obvious, but ANMs did not want a chatbot that's very chatty. Right? They wanted crisp answers, actionable answers, bullet point format. Another surprising thing was they didn't want the answer to be purely in the local language. They wanted it to be multilingual. So they wanted the body of the answer in the local language, but medical terms such as anemia, hypertension, as well as numbers in English. Right? So these were some of the learnings that we built into our design process.
Thanks, Amrita. I think let's move to another crucial, and it's an overused words, but let's talk about trust, okay, especially in the context of last mile health workers and women especially. And in my opinion, it is not just about trust alone, it is dignity and the empowerment that it brings to the last mile worker. Hamid, I'll start with you. In terms of, making it convenient is one thing, but getting a role, ASHA workers are so oppressed with the kind of work. No, it's not just about registers, but so many other work is already loaded onto them. How do you get the trust of them to convince them that it is in their own interest that they should start using your solution?
Yeah, so if you see the nature of ASHA workers' work, so they most of the time interact with the beneficiary on the field. And if they find any beneficiary in the high-risk condition, they have only one solution, that they have to refer the beneficiary to the primary health center. But now, because they have these guidelines in their hand, so what is happening in the field, like for example, if a pregnant woman is severely anemic, they will refer the beneficiary to the primary health center, but before that, with these guidelines, they can also see the guidelines and can also suggest that these are the things which you need to do, which these are the food which you need to take. And one more thing, so if they need any information, they are heavily dependent on their auxiliary nurse midwife, their supervisor, and it is not necessarily whenever ASHA worker is in the field interacting with the beneficiary and want to talk to the ANM or their supervisor, they are available on the call. So every time whenever they do not have any answer of the beneficiary required, they have to reach out to them. But now they can see all these information. So the confidence of ASHA worker is also building, that if beneficiary will ask us hard question, we have the solution and we can see the answer and we can provide the information to the beneficiary. So this is how we are building trust with these information, with these digital tool.
Right. Okay. Tanushree, when we talk about trust and what Hamid was just explaining, how it takes time for them to realize that actually it is benefit. I mean, I also recall the early days of Aadhaar. Okay, there was so much mistrust, from privacy to your data being misused, and people were also very cautious about what will happen if they give their Aadhaar to some place. But how have you realized that? What was important to gain the trust of the end users, whether it was ordinary citizen or the last mile worker who works with them? How was that achieved?
So it was a very long drawn process from day one. I'm told the initial inception or the brain children, the initial founders of Aadhaar, when they were talking about how much data should be collected, somebody wanted to collect caste, somebody wanted to collect religion and other details, because एक बार collect करना है, collect करके रख लो, life simple हो जाएगा. But they insisted that we will only collect this minimal data, right? What do you collect today? You collect the biometrics so that we can uniquely identify you. You try and get a second Aadhaar, no matter what name you will put, we will be able to identify that you have another Aadhaar with this face, this biometric and this iris, right? And similarly, we will not use, even for a different name, I will not allow you to get another Aadhaar no matter what you change in your demographics, because we can uniquely identify you because of the biometrics. So biometrics was the trump card. In addition, only name, date of birth, address, so that we can make sure that your Aadhaar reaches where you stay, right? That's the only information that is collected. To start with that, it was critical. If you look at the Aadhaar Act, back in 2016 when it was made, etc., it was ensured that the way government can use that data, it is only limited and for minimal use. Aadhaar was agnostic of the use. I will not know where. As UIDI, we don't know where you have used your Aadhaar. We are not required to know that information. It is only between you and your verifying entity, for example, your ration shop dealer and your ration shop ministry, the food and civil supplies, who will know that yes, somebody has taken ration. UIDI does not need to know. So the basic principles of data collection and data maintenance and the technology of being agnostic about the usage were critical to ensure there is trust in UIDI. Otherwise, the surveillance mindset of the skeptics would take over, and they would think that aap to kuch bhi kar sakte ho data ke sath, right? So that was one critical thing. But in addition, the ways in which we let you use your Aadhaar, you can lock your biometrics, you can lock your Aadhaar. How many of you know that you can actually go to the Aadhaar app and lock your biometrics so that nobody else can game it? So I don't see many people, but yes, please download your Aadhaar app, and we've given the power to the user to ensure that when you lock your biometrics, nobody can use it. When you lock your Aadhaar, none of the features of Aadhaar can work. It's like you having a password to your bank account, and therefore nobody else can use it. So all these features that we have enabled to give the power of the usage of Aadhaar to the resident ensured that the person can trust that the government is keeping the data in a repository which is trustworthy and is going to keep it safe.
Thanks. I think one big message, I take it, and I think everybody would agree that this feeling of surveillance is one big back of the mind constraint that have, because even if it is in their interest, they will feel that no, some matrix is being collected. How many times you are asking? Why didn't you know the answer yourself? I think it is very important that the person, last mile person in whose hands these tools are being given, should know it is only for her benefit. It is not going to be used for any other purpose, and that is very important part of it. Would you agree from your side?
Yeah, completely. And speaking of trust, we also wanted to understand first what are the other sources of information that health workers currently leverage. And we saw that health workers themselves have a framework in their mind where each information source has a certain accessibility score and a certain trust score. So the medical officer or supervisor, for example, is not very accessible, but high trust, right? Trust is really high. But they don't want to bother the supervisor for the smallest of doubts. It's a little embarrassing, right? And then the same thing comes up. Maybe the supervisor will think, I don't know my responsibilities well enough. I wasn't paying attention in the classroom. So accessibility low, trust high. A fellow A&M, for example, is much more accessible, but she may not have the same level of confidence in a peer. Online sources, most A&Ms we've spoken to understand that even though it's accessible, it's not necessarily always trustworthy. So our chatbot is positioned in a very interesting space where it is seen as trustworthy because it pulls from government protocols. So it's familiar to them. This is something they've studied in the classroom setting. It's introduced to them by Arman's program managers. There's a tech plus touch approach, right? So the touch part is a very important driver of trust. It is accessible because they can, it's a judgment-free, safe space where they can ask questions any time of the day or night. Having said that, in our early research, we saw that there were some A&Ms who did feel pressure to ask questions every day. It's a very small number of A&Ms, but we saw some patterns where A&Ms were copy-pasting the same answer, and they were cycling through a set of 10 to 20 questions. Sometimes they changed a word or two, but it was the same 10, 20 questions. So it was very obvious that she wasn't, it's not like she was forgetting what she'd already asked. There was some implicit pressure that she felt. So even in our onboarding, we do make it a point to now emphasize that this is a tool for their convenience, for their learning. It's not a surveillance tool. This is something they need to be reminded of from time to time. And trust, as you mentioned, is not a given. You have to design an experience that builds trust, and you have to keep building that relationship over time.
Thank you very much. I think so we have covered the issue of design, empowerment, okay, and the trust as well. I think what I want to touch last is because when we talk about the last mile health workforce, okay, and always the government support has to be needed. You have to go hand in hand with the government, otherwise it never scales up. So the question is about scaling. And how and working with the government is easier than what it always sounds, okay? It has both sides to it. So Hamid, I wanted to understand from you, you have worked extensively in government partnership in your things. How do you make it work? And because you have scaled to 2 states now, so how did you make it work working alongside the government? What works, what doesn't work?
Yeah, so it is very necessary. So whenever we are creating any solution for the community health worker with the government, so what is happening on the field in this AI or digital world, that we are creating solution for the community health worker, not with the community health worker. So our approach is a little bit different. So when we created this digital platform, Android application with the community health worker, we almost spent more than 2 lakh hours with the community health work in a state with in some district, and then we approached to the state to expand it to the in all the district. And same thing is happening with the Asha bot, this LLM chat bot. So we are testing it, trying it with the community health worker in the limited geography, with the district officials, and when we find it useful for the community health work, then we approach to the government to scale it. So this is our approach, how we are involving or taking support of the government to scale these type of product for the community health worker.
All right. I think just a follow-up question to both you two. and then I will come to Tanushri for something related, is that when you talk about health kind of chatbots, okay, and we hear all kind of wrong things in the news, whether it's hallucination or whether it's a answer gone completely wrong. And that is a make or break solution as well. That is also closely related to the trust. How do you handle it? Can you just first start and then I'll ask Hamid the same thing.
Yeah, so there are a few different things we do to minimize hallucinations. One, obviously cannot eliminate hallucinations entirely. This is a probabilistic system, not a deterministic system. You can minimize it. One, we make sure that answers are grounded in the protocols. And we took all of our protocols, which were very visual, converted it to Markdown to make it more machine readable. We periodically expand the knowledge base as questions come in. If they get escalated to the human in the loop, once we have the answer, that gets added to the knowledge base. So that's one part. The second part is extensive evaluations. Before we rolled out the chatbot, we did evaluations with a panel of 3 gynecologists. We had standard evaluation data sets prepared. The chatbot had to answer different questions covering all the protocols. And our expert evaluators rated each answer on a multi-dimensional rubric. So we looked at whether the answer was medically accurate and free of errors, whether it was complete, whether it was concise and clear, and whether it was satisfactory on the whole. So we wanted to make sure that we had 0 harmful medical errors, but 95% medical accuracy, not 100%, but we wanted to eliminate any errors that led to harm if implemented, and 80 to 85% satisfactory rates. This is pre-deployment. Post-deployment, for the first 500 questions, we evaluated every single question. Now we evaluate about 5 to 10% of questions every month, because we get 3,000 to 5,000 messages a month. So 5 to 10% are evaluated. And we also collect user feedback. So these are metrics that we watch very closely. We are at 98% positive user feedback. The remaining 2% get escalated to the human in the loop. And in the periodic medical evaluations, we are at 97% satisfactory rates.
Thanks, Amrita. I think, in a sense, what you are saying is there is no shortcut to extensive evaluation before you actually roll it out. Hamid, what is your view?
So, as I mentioned, that we created this bot on the guidelines of the ASHA worker, which is Government of India guidelines and state guidelines. And this bot or the knowledge base is not there to take medical decision on the basis of ASHA worker. So it is there to help ASHA worker if they have any queries. So the bot is not helping ASHA worker to make clinical decision. And we have also, before deploying it to the real user, we have also tested it with some of the ASHA worker in limited geography, and we check the accuracy of it. And before deploying the bot, the accuracy of the bot was more than 85%. And we have continuous this process, so our team member is checking all those answers which ASHA work is getting from the bot. And one more thing we did with the bot is that we also did expert in the loop. So all these query we are sending to ANMs and CHO also, and if they find anything wrong, any answer is wrong, they are informing ASHA worker, and we are improving our knowledge base on the basis of all these feedback. Yeah.
Right. I think as a follow-up, Tanushri, from your government vantage point, when you involve the private players as part of your ecosystem, like in this case, government has a ASHA ecosystem, but both Arman and Khushi Baby are working. What is the expectations that you have from them that they should fulfill before they should become officially part of the ecosystem, which you will support?
So anytime, so it's very important for government to work with civil society in general and private sector also. I mean, beautiful examples while I worked with government of Karnataka and also in Tripura. And I think what is the responsibility of the evaluator as secretary or as director to the ministry or department would be, is the solution that is coming across solving what is the pain point of the beneficiary? And at the same time, there is a cost benefit analysis also has to be done. We generally take up a POC first. especially if it's a new technology and it's a new method of solving the problem. And in the POC, we have to put adequate metrics of success. What is the definition of success? And once you evaluate it through the proper mechanism, it is after that is when you would like to scale the solution overall. There are financial implications and there's social implications. There's often an optics part of it, given the political considerations that are there. So as an officer, you have to balance out all the three aspects: value for money, beneficiary getting what we want him to or her to get, at the same time does the miracle for your political goals for your minister as well. Because these are all win-wins in a way. The more effectively I spend government money, the more money I have to spend on more initiatives. So if we balance out all the three things together, I think we generally get a good outcome.
I think we covered good ground today, right from how the solution should be designed. It's not just about convenience, it's about dignity, it's about burden, it's non-surveillance. So many things that we talked about, it's about safety. So I think we covered that in terms of reimagining the whole how AI can be used for community health workforce instead of just talking about skilling. Unless all these things fall into their slot very well, there is no skilling because it will not be adopted. That trust at the end of it is important, which is the mixture of all these three things. I think thanks to the audience, but I think don't get up because we have some time for some questions from the audience and I would really appreciate. Yes, please.
Hi, my name is Abhinav. I'm a researcher and technology and policy researcher. Yeah, I think this works. Hi, my name is Abhinav. I'm a technology and policy researcher working with a non-profit. We've done a bunch of work around digital health and health AI, and including talking to ASHA workers. So a couple of questions. I think one is a technological question. You've mentioned a couple of times that the answers that the bot gives are protocol driven, right? And you've also talked about that the clinical decision making element of it is a little limited. So I think my first question is why an LLM and why not another technology like rules-based systems or small language systems that are not that compute intensive, do not require that amount of data, especially if you're working with a closed set of government documents and government protocols. A linked question to this is if it is an LLM, is it a proprietary LLM that you folks use? Sorry, or is it an open source LLM that you use? The second question I can also say right now, it's a little about the trust aspect only, but I'm trying to rephrase it from the point of view of patients. So a bunch of ASHA workers we've talked to have told us how when they do provide a solution that they've gotten on the chatbot and it has not worked for the patient, it affects their trust inside the community and not as much as the chatbots, like their trust with the chatbot. So I think my question a little is that the entire idea of ASHA workers was to localize intelligence, localize medical intelligence, make sure that the person who provides the medical decisions is contextualized with the same environment. But LLMs essentially do the other way around. You provide them an input and the model in the backend, which is more or less a black box, gives them an answer which they can, like you said, go through a feedback loop. I think my question is a little about how that intelligence can be brought back to the ground and how are you contextualizing your models through to local realities? Sorry.
I am a moderator, I should not be answering questions, but in the interest of time, I thought I'll do that. So your first question was about why not rule-based, why LLM? See, LLM is the necessary layer which makes this whole transaction conversational. Rule-based, one of the major drawbacks of the rule-based is that if then else kind of thing is there, okay? That does not give any comfort. That was good for some time when it was the only technology available. So that is the power of conversation that LLMs do. It can converse with you. You can ask follow-up questions, all that stuff. The second one is you talked about the proprietary, and I'm talking in general. I don't know exactly how they do, but I broadly know. Is that there is a technology called RAG, Retrieval Augmented Generation. You must have heard of it. So LLM is only the front-end conversational layer. The actual knowledge base is being accessed through RAG. So it does not matter whether it's proprietary or it isn't, because we are using it for very specific kind of purpose. That is the way LLM is being used. So here proprietary LLM knowledge base is not, or the model is not being exploited to answer the question directly. No, I think we'll give it the chance to somebody
We
else.
can chat after the session. There's 10 seconds left.
Hi, I'm Lakshmi and I'm currently researching in Femtech. I have a question about a lot of the products that come up when it comes to specifically women's health. A lot of them sometimes work just as AI wrapper products because everybody wants to just ride the wave, right? But okay, that's interesting. But to basically, like my question is essentially around when you're trying to not reinvent the wheel, because a lot of these functional and successful products actually just scale through tech and allow you to do better. How do you also not just make like, oh, we are working for women as the only moat to survive in the ecosystem, and do products like that actually have a scope to work with the government or to actually be scaled in the market?
I didn't fully understand your question. Sorry, time's up.
Right.
We can chat afterwards.
Okay,
now
that sounds
there's like this giant.
Yeah, sorry for running out of time, but
That's
thanks a
okay.
lot. I
Thank
think
you.
we can continue this chat outside. Thanks a lot for your patience. Yeah, and thanks the panelists. Thank you.
requesting all the speakers
Hello.
and the table facilitators to come on the front for a quick picture, and then we can start the session.
Okay, good afternoon, everyone. Thank you so much for joining us this afternoon. I promise that this is going to be a very interesting session. But before I start, as is always true in anything related to education, I get to ask a question. So my question to you is, when you see the phrase 1 billion futures, what occurs to you? What comes to your mind? Quickly. 1.2 billion.